Spine Institute, and it is August 18, 2020. We're performing a Duke laser disc repair, lumbar, one level, one side. This patient has a herniated disc at L4-5 with a slippage of her bones called the spondylolisthesis, grade 1. That's her x-ray now. Oh, she had a sacroplasty.
Yes.
Yeah, so this patient, you're going to look at her films and you're going to see some black dye in her sacrum. That was a sacroplasty. So she had a fracture of her sacrum or tailbone, and she was having pain in her sacrum, and we diagnosed her with a sacral fracture on CAT scan. Dr. Patel did a S1 sacroplasty on both sides to treat her fracture. That took her sacral pain away, but she still had pain higher up her spine at L4-5, which is where she had a herniated disc, and spondylolisthesis, grade 1. She's having pain from the L4-5 disc. People don't get pain from spondylolisthesis. This is Dr. Duke Majan. Are you awake? Yeah. I'm going to give you an injection. It's going to hurt a little bit, okay? Don't try to move or get off the table. If you want to do anything, just say ouch. I'll try to make it so it doesn't hurt too bad, okay? All right. This is going to be one of the more uncomfortable moments, and then we're going to put you to sleep in a little bit. Okay? Deal? All right. If you feel pain, just say ouch, okay? You let me know if you're having any discomfort. You're going to have a little bit, that's normal. But if it's bad, just say ouch. Don't move on the table, though. Right side, everybody agrees? Right L4-5? You're doing great. Just hang in there. Let me know if you're having any pain in your leg. Shot. Let's go lateral. I don't know if that's 3-4 or if that's 4-5. It may be 3-4. We'll have to see. Yeah, it's 3-4. So we need to go further down. You can see the listhesis at 4-5. All right, is that the best picture we can do? I think it's pretty close to being perfect, actually. Just get another shot. All right, that's good. So the pedicles are lined up nicely. I just need to aim a little bit further south, and we'll be fine. Shot. That's too far south. Shot. That's a little better. You okay? Shot. Shot. That's got to be the facet joint. Shot. Shot. Getting there. AP. Better than I thought. Back to a lateral, please. It's always hard to tell where you are with just one picture. You need really 2 or 3 views. The 2 views we use are the lateral, which is side to side, and AP, which is front to back. And really, sometimes we use what's called an oblique view. Shot. Where do you feel that? Where do you feel it? Not down your leg? Shot. Which leg? How far down? Oh, just to the knee, but not past your knee. Shot. Is that it right there? All right. You feel it in your back? Huh?
You feel in the back? Right? No.
Yeah, right where I'm at. All right. Well, this is your herniation. That's what we're here to fix. Shot. All right. Shot. Yeah, it's in the disc. Do you get much back pain?
No.
What do you get? Leg pain? Huh? I can't hear. Leg and butt. Are you comfortable? Is that your typical pain? It's on both sides. I love it, bilateral. Is that where you typically get your back pain? How bad is that on a scale of 1 to 10? What's the worst it got? 10. L45, 10 out of 10. We're all in agreement that's the L45, right? Okay, we're going to go to sleep. When you wake up, we'll be done. You did good. Count out loud for me from 1 to 100. So we tested the L45 disc, and there's a big tear. The dye is leaking out through the back of the tear into the epidural space around the nerve root. Yeah. You're doing good. Shot. Shot. You're doing fine. Everything's okay so far. Are you comfortable? So we do a little skin incision, 7 millimeters. So this incision for the surgery is just 7 millimeters. It's tiny. It's the smallest incision you can make for spine surgery. All right, just relax. Everything's okay. Shot. Let me know when I can proceed. So this stage, I'm bringing what's called a dilator, which spreads the tissue open as it runs down the guide wire. The guide wire, we know, is in a safe area because we use the needle to get in, and I feel confident we're in a good place. So the dilator goes down the guide wire. The guide wire guides it to the herniation, where the herniation is. Shot. Right next to the facet joint right now. You're doing fine, Shot. All right. Shot. Let's get we're right at the disc now. Shot. All right, now let's get an AP. So the thing about spondylolisthesis is it stretches the disc from its normal location, and the bone at the top that's sliding forward is going to pull the disc forward. So it's exactly where we are. It's perfect. Lateral. Just what we would expect. So instead of the disc being where it's supposed to be, it actually gets stretched forward with the bone that's sliding forward. Yep. So right now we're about to enter the tear in the disc. Shot. Let's have we're going to go through that tear, and we're going to advance the dilator into the disc. Shot. Everything's okay. There it goes. Take the guide wire out. Let's see. Is that it?
Yes, sir.
All right, so we're inside the disc. Now, the place we're entering on the right side, we're going through a foramen, a natural hole that's already there. It's called the neuroforamen, and there's a herniation in that foramen, a herniated disc. It's bulging out, and it's hitting on her nerve root going down her right leg. So I'm going to be removing that bulging disc while I'm here. Shot. All right, you can see the tubular retractors entering the disc space right now. Shot. Shot. It's sliding down the dilator. It's engaged with the dilator, and it's moving the dilator forward. Shot. Okay, shot again. Perfect. We're inside the disc. Let's get this herniation out of here. This procedure you're watching is endoscopic spine surgery. It is the future of all spine surgery. Unfortunately, less than 1% of spine surgeons know how to do this, any kind of endoscopic surgery like this. So there's only a few in the world that are able to do this kind of endoscopic surgery. Okay, with a tiny little incision and a tiny tube. Other surgeons call endoscopic spine surgery what they call, turn off the water, but they're actually doing a much bigger incision. True endoscopic surgery is done with a 7mm incision, or in the neck a 4mm incision, just like we're doing here, 7mm. Other spine surgeons make big incision and they call it endoscopic, but it's not really endoscopic. They do it more because they don't know how to do true endoscopic surgery, or because they use it for marketing. All right. So, true endoscopic spine surgery, which is what we're doing here, is incredible surgery. It really will take over all the spine surgery that's typically done, any surgery for degenerative conditions. Degenerative or even disc trauma. Grabber. So we're inside the disc, right inside the herniation. You can see the bones on either side right there. That's a piece of herniation right there I'm taking out. Okay. It's stained blue because herniated discs stain blue with a special dye I use. I can't take credit for the use of the dye. It was taught to me by my predecessors who taught me the basics of this type of surgery. But the dye is indigo carmine. A lot of people think it's methylene blue, but it's not. It's indigo carmine. Indigo carmine dye stains degenerated discs. Lasers on at 30?
Yes, sir.
All right, good. Nice work, guys and gals.
Yep.
This will be our last surgery for the day, so if you have questions, this would be a good time to ask them. The reason why it's so hard to see is that there's a lot of blue dye still coming out. I injected the whole syringe. So we're going to be, there's a big piece of herniation right there. Stand by. See that right there? I'm going to just pull it out. If I can get it. There it is. See that? That's what a herniated disc looks like. Well, of course, stained blue. Here it comes. I'm twisting it out. There it is. Just to show you what it looks like. Here it comes. Bam. Can we get a light on and we'll show our audience? For the people who have hardcore, can you see this, Sean? Put in the light.
Yes, we can.
See that big chunk of herniated disc right there? We just fit. No, move your hand, Sam. Move your hand. Move your hand. Right there. All right. We'll send that to the lab for examination. Anyway, you can see the advantages of this surgery over a traditional microdiscectomy. A microdiscectomy would definitely, if it's done properly, which a lot of doctors don't do it properly, it'll help with the leg symptoms, but it does nothing for back pain. You do microdiscectomy for back pain. You can do Duke laser disc repair, which is what we're doing right now. That works for back pain. Okay? So let's pull back a little bit. There's the tear right there. You see it? That's what the Duke laser disc repair fixes. The only surgery in the world that fixes the tear. And it's the first surgery in the world to ever fix the tear, because I'm the one who pioneered that surgery. And we published it. We're the first in the world to publish repairing or debriding the annular tear, basically. It's a debridement. The body itself will heal it once we debride it. Stand by. There's another piece of herniation. I'm going to try to fish it out using the pituitary. The pituitary is a pretty standard tool in neurosurgery. It's used for brain surgery, spine surgery. It's essentially a grabber of tissue. And the pituitary rongeur that we use is designed to be used endoscopically. It's designed to go down this long, skinny tube. Now, the ones that most neurosurgeons use the normal ones, they can't go down these long skinny tubes. So these are specially designed pituitaries for endoscopic spine surgery. There's another piece of herniation right there. We'll get it out. All in good time. I have a feeling she's going to do quite well once she's healed up from the surgery. This is all part of the herniation. The end plate is up there. You have another question, Sean?
We do not.
All right, standby laser. Let me see if I can grab some more of this herniated disc out. Again, you can see it doesn't want to come out as one big piece. It wants to come out as little pieces. So we're just going to have to whittle away with the laser. It's pretty characteristic of herniations. They don't like coming out as one piece. They want to make you work for it. This is all the area of the herniation that was pushing on her nerve, right here. And there's a little bit of blood. Sam, I don't know how. You got to give me a little more slack. Take that. Nope. Grab her. That's another piece of herniation. We're right in the foramen at this point, just outside the disc. And these are all pieces of the herniation. That was in the foramen. Take. Let me see that grabber again. All right, let me clean up that annulus laser. I need 5 more minutes, or 3 minutes actually. Sam, I don't know what you're doing, but I cannot get my laser to cooperate. You gotta let go of the fiber, please. Huh? I have to be able to move it around. Let go of the fiber. This pedal has stopped. Do you have the laser off? Huh? Yeah, did you turn it off? Yeah, don't turn it off unless I ask for it to go off. Or if you see me take the fiber out completely. Okay? Cam? Why is there a bubble? Do we have more irrigation? I'm sorry? Okay, good. I don't care if it's cold. So we're not fixing this patient's listhesis. All we're doing is repairing her disc injury with the Duke laser disc repair. It can only be done at Duke Spine Institute, by the way. So if this patient had gone anywhere else, they would have had a spinal fusion done. That's what most surgeons do for her problem of pain in the leg, pain in the back, and a spondylolisthesis. So she got lucky, she found us, and she decided she didn't want a fusion, she wanted a minimally invasive procedure, the Duke laser disc repair. Just about done. Another minute, we're done. A little bit of epidural fat up there. Yep. The nerve root's going to be right up there in that fat. And that's a good discectomy and annular debridement. It's amazing, huh? The appearance of the disc in this lady. She's not young by any means, yet her disc is pretty well preserved. Let's have the grabber. See if there's any more herniation I can get out. See if that will come out. How's she doing? She looks like she's coming awake. There's the last piece of herniation right there. That was a good one. All right, we're done. Take.
Lights on, please. Scrub off, please.
Let's have the dilator. And then medicine. Oh, I need the suction on, guys. Come on. You guys can turn the suction off when the tube comes out, but not before. Pressure. All right, we're done. I expect her leg and back pain to be gone. Let's show the audience our incision right here. See that there, Sean? 7 millimeters.
Yes, we do.
Pressure. Good work, everybody. Done by 5. Not even 5 o'clock. Yeah, 5 o'clock. Quitting time. Our fusion patient's already gone. Our laser surgery before that we already did is gone. And this is our last patient. She'll probably be gone in about 30-45 minutes. I'll call our EBL 1 mil. No complication. This is a right. Is that right or left? Right. Right, L45? What was our discogram? You got to mark the discogram. I know. And it was concordant. All right. Thank you. Nice work, everyone.
We do not have any at the moment. All right, everyone. Thank you for joining us for the post-op Q&A. This concludes our day of surgery here. We had an exciting day with a lower lumbar fusion this morning, a T-lift. It took us about 4 hours to get through that, followed by 2 short DLDRs on the lumbar spine, both at L4-5, one on the right side, one on the left. We're wrapping up our final surgery now. We have Dr. Duke in the room with us to answer some questions. If you have any remaining, type them up in the chat now. Otherwise, I'm handing the mic over to him for a little while.
Okay, folks, we're glad you could join us for the surgery. This is spine surgery coming from Duke Spine Institute, here located in Melbourne, Florida, and we broadcast all of our spine surgeries live over the internet for the public to watch and learn. We answer questions during the surgery. We don't edit any of our surgeries. They're all free-form, fully 100% broadcast live. Unedited, unmanipulated. You get to hear and see, almost taste and smell everything happening in the operating room with us, with the team. So we obviously don't show you any of the nude stuff, but you get to see what the surgeon sees in the operating room. You get to see the back, the neck. You know, you get to see what's called the operative window. And you get to go through the surgery with me, with the incision usually, and then step by step what I do to do the surgery. So we do this because we want the world to see how the most advanced spine surgeries currently in 2020 are being done. We've been doing these surgeries and broadcasts now for 7 years from Duke Spine Institute. It's always free. It's always open to the entire public around the world. We don't restrict access to these videos to anyone who wants to watch and learn. And we have a question coming up. But this lady that we just did her surgery, I can't remember her age. What do we say she was? Close to, I think she's 70, perhaps. She's been suffering with back pain shooting down her leg. It was her right leg. And when we did her MRI, we found that there was a herniated disc at L4-5, which is the most common, by the way, the most common disc in the lumbar spine to herniate and cause symptoms is L4-5. And not only did she have a herniated disc, but she also had slippage of one bone on the other. That's called spondylolisthesis. Listhese means to slip in Latin. Spondylo is the spine. Spondylolisthesis, slippage of the spine. Common issue. And it's one where most spine surgeons would see that and say, let's fuse, okay? But you don't need a fusion because the listhesis itself isn't the problem. It's the herniated disc, an annular tear. And that's what I figured out from years of practicing medicine and doing spine surgery is I learned that I could fix these patients' problem without doing a fusion. It can be done endoscopically, transforaminally with the Duke laser disc repair procedure you just watched, using a laser, using an endoscope, and using a 7mm incision. The surgery takes about 30 minutes per level. She was only a single level, L4-5, one side, so we're already done. And she's going to be out of here in about 45 minutes going home. This is not a hospital surgery. You don't have to go to the hospital. You come to Duke Spine Institute. It's outpatient. You come in, you come out, 2 hours later, and you're done. The pain you come in with should be gone, whether it's in your back, your leg, or it's in your neck and your arm. That's how quick it is. It's basically a modern-day miracle of the spine to be able to fix herniated discs that are causing pain quickly, efficiently, and safely without complications. I've done about 1,150 of these surgeries now, and we've had a reherniation rate of about 1%, so a little bit over 1%. We're at about 1.1% reherniation rate. That means that in 100 people having the surgery, one of them will have another herniation, usually as a result of bending or lifting something they're not supposed to or some activity they're not supposed to do. And that causes a reherniation. So you just do too much. You got to let the disc heal, folks. If you have this Duke laser disc repair surgery, you got to give it 3 months, 6 months, even a full year, really, to be safe before you do any heavy lifting, bending, twisting. But after a year, you can do whatever you want. Your disc will be completely healed and solid. What's our question, Sean?
A viewer wondering, how common are symptomatic thoracic herniations?
So the question is, how common are symptomatic thoracic disc herniations? Great question. The thoracic spine is one of the four parts of the spine. The spine has really four parts. The cervical spine, which is in the neck, the thoracic spine, which is from the base of the neck down to where the ribs end, and then the lumbar spine, which is the most common problematic area of the spine. It's the lower back. And then you got the tailbone, which is your sacrum. The sacrum almost never has problems. It did in this lady. She fractured it because she has osteoporosis, and we did a sacroplasty, which is injecting cement into it. But that was not today. That was done by my partner, Dr. Patel, and that was a month or so ago. She healed up from that. Her symptoms went away from that. And now she had lumbar spine pain from a lumbar disc herniation. So the question is, how common are thoracic disc herniation symptomatic? Thoracic disc herniations are not as common as lumbar herniations or cervical. That means they're not as common as the herniations in the neck or the lower back. And the reason for that is because the thoracic spine is much more stable automatically to begin with. You're born with a more stable thoracic spine. That's because of the ribs. The ribs connect the spine to the rib cage or breastbone through the rib cage, and those ribs provide a lot of stability to the thoracic spine. So disc injuries in the thoracic spine are rare. Just to have a disc injury is pretty rare. But then to have one that causes pain, whether it's pain in the middle of the spine or it's pain that radiates around the rib along the nerve root, it's not that common. Probably represents 5% or less of spinal disc related symptomatic disc herniations, okay? Symptomatic thoracic disc herniations represent less than 5% of all disc herniations. Probably 65% of symptomatic disc herniations are in the lower back. Probably 30% of symptomatic disc herniations are in the neck, and then 5% are in the thoracic, which is the area between the neck and the lower back. That was our last question. So it was a good day. Our patients are doing well. I can tell you right now, if you did not see the fusion surgery patient after her surgery, we did a live broadcast. She's standing up and getting ready to go home in the recovery area. Her back pain that she had before surgery, gone. Her leg pain, gone. She has muscle pain from me cutting her open and moving the muscles. That pain will go away from her muscles in about 2 weeks. She's already gone home, and the laser surgery we did before this one already went home, and her back and leg pain were gone. Miracles. So people tell me on the internet all the time, I see people talking about how, oh, chronic back pain can't be cured. Nonsense. It can be cured. You have to go to Duke Spine Institute. Oh, chronic neck pain can't be cured. Nonsense. It can be cured. You have to go to Duke Spine Institute. All right? I don't know how better to explain it to you, but if you want the results that are available, the best results in the world that are available, you have to go to the best place in the world that provides those results on a daily basis. And I can tell you 99% of spine centers don't offer cures for neck and back pain. They'll tell you there's a 50-50 chance you'll get better. Not at Duke Spine Institute. There's a 100% chance you're going to get better. We've never had a patient that didn't get better. Now, do people go out and sometimes do things they're not supposed to do and they injure their spine again, or do they have pain adjacent to where we operated? Yes, that's possible. If people have those type of pain, they come back to us, we figure it out right away, and we treat it right away. So for example, the L5-S1 disc, right, very commonly causes back pain. So let's go fix it. And then the patient comes back and now they have pain in that area, but it's not coming from the L5-S1 disc, it's coming from the SI joint, the sacroiliac joint. Very, very common for us to see people that have more than one, we call it multiple means more than one, multiple sources of pain. And you can't fix multiple sources of pain by fixing one source of pain. So if the L5-S1 disc herniation is one source of that pain, and they're having also pain coming from the SI joint on the left side, we also have to fix the SI joint on the left side, not just the L5S1 disc herniation. I hope that makes sense to you all, but it's very important point. About, I would say 50%, anywhere between 40 to 50% of the patients we see have more than one source of their pain. And really, we have to treat all those sources to get rid of the pain. Well, I don't have anything else to say. The surgery was a success. I hope you enjoyed it. It was an endoscopic laser spine surgery done here at Duke Spine Institute. If you would like to have your MRI reviewed for free, just go to the website, mri.dukespine.com, or go to dukespine.com, or even go to the Duke Spine Institute app. It's free. You can download it on your phone. Once you have it downloaded, you could submit your MRI using the app, and we do a free review for you, no charge. We could also do a teleconference for free for about 10 to 15 minutes, no charge. We offer all these free services. Why? Because we want to help people get out of pain. That's why. All right, have a good evening, and we'll see you next Tuesday. Oh, next Tuesday is a beast of a case. We have a major revision surgery with multi-level fusion. Not something I'm looking forward to. But this patient has really bad pain above their fusion, and I'm going to go in there and do my best to fix it. So it'll be a long surgery, a long fusion surgery, lumbar. Hopefully we'll see you next week. Bye-bye now.